So my name is Vineet Chopra. I am a hospitalist, which is an internal medicine physician who works in the hospital only. I've been an internist for now 15 years, and I currently oversee the Division of Hospital Medicine at Michigan Medicine. So this is a division within the department. We have 132 faculty in our division who are hospitalists. Many of us do clinical work, but some of us also do a lot of research work. And most of the research in hospital medicine is focused on patient safety and quality. And so that is our big area of interest. Magic and a lot of the research in hospital medicine comes out of a good clinical question. So in 2009, when I was not yet a researcher and was thinking about my career, I took care of a patient who had chronic pancreatitis, was admitted to the hospital literally every few weeks with pain and nausea and vomiting, and needed to have central access for things like calcium gluconate and TPN. And she would get a peripherally inserted central catheter or a PICC line on every admission. Now, in 2009, there was nothing to say this was not bad practice. Everyone did this. And so I was one of her providers caring for her in one admission, and we put a PICC inside her. And unfortunately, a few days later, she started to have pain in the arm and swelling in the arm, and she developed a big, deep vein thrombosis. So this got me interested in thinking about, well, why did we choose that line? And could I have done something better? Could we have actually prevented that complication? So when you go and look in the literature, at the time there was nothing published on risks of PICCs. In fact, most of the literature I saw back in those days was around they were safer than central venous catheters. They were less likely to have insertion complications. They were convenient for patients because bedside nurses could actually put them in at the bedside, no operating room, no big procedure, and certainly no trauma to the vessels of the neck and the chest, pneumothorax, laceration of the vessels, none of that risk. So everyone was using them. At that point in time, I became sort of interested in a research career, and I decided to focus a lot on venous access. For the listeners of this interview, if you think about the most commonly performed procedure in the hospital across the world, the number one most common procedure is venous access. Everyone gets it when they hit the hospital. And yet, when you look at the research underlying those decisions, there's very little published in terms of what device is best, why is it better than the other device, what's safest for a patient. And so it immediately became clear to me, given my interactions with this patient that I was caring for, and this really fundamental decision that we hospitalists and internists make every day, that this would be a very ripe area for research. So I began to get very well trained. I took 2 years and did a research fellowship. And one of my goals was to develop some type of criteria for when you should versus should not use a device like a PICC. And that was the origin of the Michigan Appropriateness Guide for Intravenous Catheters, or MAGIC. Though unlike other criteria, what I did not want to do was to go back and look at the evidence or the lack of evidence, frankly, and come up with my own things that I thought were important, largely because I knew that that would have a limited impact. When you think about a vascular access device or a venous access device, there are so many stakeholders. There's the intensivist, there's a surgeon, there's a bedside nurse, there's a vascular access professional or an operator, there's nephrology, there's infectious diseases, there's cancer doctors. And so I stumbled on this methodology called the RAND UCLA methodology that allows people from different backgrounds to come together to develop what they call appropriateness criteria. A few words on this method is really well suited for MAGIC. So one, the goal of this methodology is not to have everyone agree. So it's very different from other sort of consensus methodologies where the goal is consensus. The goal is everyone has to agree. In the RAND UCLA method, the goal is that everyone has to understand what they're either agreeing or disagreeing on. So the idea is that there's very clear specification of the decisions that are being made and the factors that go into those decisions. The second aspect that's really nice about the methodology is it allows for individuals to express their views based upon their specialty. So in the first round of ratings for MAGIC, we sent everyone the scenarios for voting independent of one another. So the infectious disease doctors made their own votes, the nephrologist made their own votes, the vascular access nurse made her own notes, and the internists made their own notes. And in so doing, we got 15 different specialties together for the very first time to come up with what they thought was the most appropriate use of not just a PIC, but other vascular access devices. That's the big thing about MAGIC is the goal is not to say, use or don't use. It's use the following device because it has the best safety for that patient, for that indication. So that's how the process started. I will say, it was a very laborious and time-intensive process. We started off with systematic reviews of the evidence and literature syntheses. We had to identify 15 experts in different specialties. For those of you who know in the clinical work, to try to get a surgeon and an infectious disease doctor and a cancer doctor to agree in clinical care is very different. To have them do this on evidence was even more challenging, but we made it through. And the beauty about MAGIC, I think, is number one is that all the voices of stakeholders were incorporated. And it was really nice to see diverse people coming together to talk about this. Number two, what was very unusual about MAGIC was that we included a patient. And that patient that was included was actually the same patient I cared for that got me started on this journey. And she has been a partner for me now over a decade with respect to thinking about the patient's voice and why it's important to include the patient on decision making. As proof of the process, this patient actually ended up getting a port after she developed her DVT with a PIC. Her port was placed in 2010, and she still has it today in 2018. And so even when we talk at our meetings and she's still a part of our research and provides input, she points to her port on her chest as a sort of a real world, I live with this decision every day, and this helps me every day get clinical care. So that's the origin of MAGIC. That's the bit of the background. That's why it's important. When I see her, I always remember that the work that we're doing affects countless of people in innumerable ways. It's important work, and I'm glad that you're highlighting it for the Italian Society of Internal Medicine. I want us to think about this in the context of what I call the 3 I's. The first I is inertia. And by inertia, I mean failure to actually think about the decision, right? In the US, we have very specialized vascular access teams in most hospitals. In many ways, they are the path of least resistance. When I was a trainee, if your patient couldn't get IV access, they would call you and they would say, I can't get blood. What do you want me to do? You sure this person needs another IV? Can't find anything. Why don't you come and assess? And it was a real challenge. And I would ask myself, do I really need that blood draw? Do they really need that IV antibiotic? Maybe I could switch to an oral antibiotic. And boy, if they need access, maybe it's going to need to be something more invasive. Is that the best choice for the patient? With the evolution of vascular access teams, all of that decision-making has gone away. So this is the inertia piece. It is the easiest thing to do now in most hospitals in this country, which is you just type in the word PICC, and magically your patient gets a PIC. So that's the first risk factor, is inertia. I think the second risk factor, and one that has become very much, I think, more important, is inexperience. And that's the second I. And what I mean by that is when you look around today at trainees and at faculty and you ask them, how many central lines have you placed in your career? How many peripheral IVs have you placed in your career? I see a erosion of skills because many of them aren't doing them as much as they used to anymore. And again, this has to do with the evolution of medicine. We now have radiologists and surgeons and all kinds of really nice teams to help us with this, and that's good. But I also think that you need to have a certain skill set in the setting where you must make a decision and must do a procedure And I think inexperience is the second I, where I think people often will make the wrong decisions about inappropriate central venous access. And I think the third, and this is the focus I have had for the past decade of my career, is what I call inadequacy, and it's inadequacy of knowledge. So people did not fully know what the risks of a PIC were, what the risks of a central line were, what the benefits are, where should you choose one peripheral device over a central device. We, in fact, did a study that we published about 6 years ago where we went around and looked at how often patients had PICs and how often their doctors even knew that they had a PIC. I can tell you today, when you put a central line in a patient, you never forget that, right? Because that was an hour of your life. There was a risk you took, and you own that line. With PICs, that ownership is gone. And so when we did the study, 1 in 5 doctors did not know that their patient had a PIC when they actually had one. And I think this comes back to the whole inadequate knowledge piece. Out of sight is out of mind. PICs hide behind the arms. They look a lot like peripheral IVs when they're hooked up. You don't see where the tip is. And if you think of those three things together, that's why I think you have a lot of inappropriate use. We have inertia, we have inexperience, and then we have inadequate knowledge. You put those three things together, I think you have the perfect storm for inappropriate use of central lines. I think if you look at the magic algorithm, it breaks it down, but let me even make it simpler than that. I think the first decision is, does this patient need central access for any reason, or do they need peripheral access? And when I think about central access, I think about the following. Do they need hemodynamic monitoring? Do you need to look at central venous pressures? Are you going to give them a drug that is an irritant or a vesicant such that the peripheral veins will be damaged irreversibly were you to infuse it? That becomes challenging a little bit because every drug is a poison. The only difference is duration and dose of the drug. And so, for example, 24 to 48 hours of vancomycin given empirically for pneumonia. Yes, it is an irritant and a vesicant, but it should not be given through a central line if it's empiric treatment. So you need a little bit of judgment there. But if it's not a centrally administered medication, or for that matter, nutrition, parenteral nutrition, there really should not be a reason to think about a central device. So I think the first decision is, do you need peripheral access or central access? If you need peripheral access, which is the path of the algorithm I'm going to walk you towards now, the question is, does this patient have difficult access and you can't get something peripherally? And again, in difficult access, you have to think about a definition that makes sense from an operational perspective, because difficult for me may not be difficult for somebody who does this for a living every day. So the common definition is no visible veins, no palpable veins, and at least an experienced operator has tried 2 or more times and has not had success. And I use 2 as the cutoff because I think after 2 it becomes cruel to actually use patients to sort of find veins. So if they have difficult access but the need is still peripheral, the next step is to actually go into using technologies. Just to sense a little bit of who these patients are, these are very much medicine patients, right? They tend to be patients who are obese, patients who are malnourished, extremes of that spectrum, patients who have chronic or complicated diseases who come in and out of the hospital, so autoimmune diseases or patients who have drug use, who are frequently admitted. They often will not have veins. And I think patients who often will need cancer treatments, they often will look like this phenotype. So for those patients in those settings where you still need peripheral access, the adoption is really the 3 choices. So it's a peripheral IV catheter, it's an ultrasound-guided IV catheter, or a midline catheter. How do I choose between those 3? It's very simple for the peripheral IV catheter. If you can't see a vein and you can't feel a vein, my rule is never try to find a vein, because you're not going to find it. So the next step is to use either ultrasound or to use infrared technology to visualize and see if you can find something. I will say with ultrasound, once you get skilled at it, you really get very good at finding veins in the arm. The additional sort of element here is there are also longer peripheral IV catheters that range from the 4 to 5 centimeters all the way up to 8 to 10 centimeters that can find deeper veins. And so using an ultrasound can help you find those peripheral veins. I will use peripheral catheters for a duration of no more than 5 to 7 days. Beyond that time, the veins start to get into trouble. You often have to think about changing the site. And in somebody who has limited venous access, you have to think about what are you going to do long term if you keep rotating IVs every 7 days. So when you're thinking about central access, I think about a central venous catheter in the neck or the chest or the groin, a PICC, a tunnel catheter, and a port. I think about central venous catheters as devices that are short-term use, especially when placed in the neck or the chest. So if you're a critically ill patient, that is in my mind, the most appropriate device for you. The reason that's true is because in our meta-analysis that we published in Lancet, we found a much lower risk of thrombosis in patients who have a central venous catheter than a PICC. The risk was 2.5 times greater if you had a PICC than a central venous catheter. So in the ICU, where you have a very high risk for thrombosis to begin with, the PICC is not the optimal choice. You should be thinking about an acute, non-tunneled central venous catheter, either in the internal jugular, subclavian, or in the femoral, depending on the patient's anatomy and your comfort in inserting the line. If you need prolonged access, especially if a patient is going to transition out of the hospital, the choices are essentially threefold. It's the PICC, it's the tunnel catheter, and the port. The PICC is often the go-to device, and I often think about PICCs for less than 3 months of use. And the reason I have a 3-month cutoff in my head is because the people that need longer access beyond 3 months often need something that is more permanent and something that is less prone to dislodgement or less prone to infection. And so if it's 3 months or less, typically if it's somebody who needs, say, 6 to 8 weeks of IV antibiotics, or somebody who needs short-term nutrition support, the PICC is really a good choice. In particular, in choosing PICCs for those patients, the recommendation always is to use the least number of lumens possible. We have found the lower the lumens, the lower the risk of infection, the lower the risk of thrombosis, because the lumen size increases catheter size. And so single lumen PICCs is what we recommend for long-term use up until 3 months. Beyond 3 months, we often end up with people who need nutrition or people who need chemotherapy. And I think those two are sort of different sort of patients. Patients who need chemotherapy, the port is the ideal device in many ways because they can come, get infused, and also have it removed, and can go out then and live their life without a catheter being in place. This means they can shower. This means they can swim. They have a good quality of life with the port. There's also a much lower risk of infection and DVT. We use tunnel catheters in patients where the overall prognosis or the overall need is unclear. So specifically where patients need nutrition, but there's some chance of recovery of the gut, or if patients need some type of long-term support where the hope is there will be a cure at the end. We recommend tunneled catheters. Now, in retrospect, you can tunnel a PICC catheter and it becomes a tunnel catheter. The big advantage of the tunnel is that there is space between the skin entry site and the vein entry site, and that space creates a natural barrier to infection. So infections can still occur from the entry site on the skin, but they tend to be much less frequent when you tunnel. The big risk is infections from the actual catheter hub or the lumens of the catheter. And for those reasons, we always, again, recommend single lumen catheters in those patients as well. So my thinking for central catheter use is at the 3-month timeline. Anything before that, I think a PICC is a reasonable choice. Anything beyond that, it depends on the type of patient. If it's chemotherapy, I think the port is a better choice. If it's nutrition, then a tunnel catheter may be appropriate, especially if you're thinking about recovery of function. I think a couple of things about elderly patients. One is they tend to be less mobile. And when they're less mobile, there's a higher risk of thrombosis. We know that the risk of DVT goes up with age. And so I always think of patients 65 and older as being a little bit at higher risk than patients who are younger. That's number one. Number two, I worry about the elderly patient because I think of them as having limited venous real estate. In other words, they have a limited number of veins. Especially for those who are chronically ill, there's likely going to be repeated hospitalizations, and I worry about recurrent punctures on the vein. Remember, the more you puncture, the more you have endothelial trauma. The more endothelial trauma in an inflamed patient, you have two of the three Virchow's factors working towards thrombosis. And I also know elderly patients tend to get more confusion in the hospital. I can't begin to tell you how many times we put in a PIC in an elderly patient only to find the next day it's lying on the bed because they thought it was a snake, they thought it was a phone, and they pulled it out. When it's 7 to 10 days, I think a midline is a very good choice. And there's a couple of reasons. One, they're much more durable than a peripheral catheter. Two, you need one device for the entire stay. If you're going beyond 7 days, more often than not, you'll need more than one device. And three, you can use it for blood draws. So unlike a peripheral catheter where often you'll see the skin of elderly patients with all kinds of bruises and ecchymosis from blood draws and peripheral catheters and trauma and skin tears, I think a midline makes a lot of sense for that patient. And again, placing the midline, upper arm, so that it is cured and harder to actually pull out, will get you through one device for that one patient for their entire hospitalization. That should be the goal of making those decisions.